Thanks so much, Alan and Rena and the organizers for inviting me. I'm going to focus on the role of HIV and viral co-infections in contributing to the persistent inflammatory state and to end organ disease. These are my disclosures. And the first focus is whether HIV itself is a direct cause of the persistent immune activation we see during otherwise suppressive ART. We learned from the SMART study that ongoing HIV replication in the absence of therapy likely drives many end organ diseases, in particular cardiovascular disease. But the question for us now that most patients can achieve and maintain viral suppression is whether the virus continues to directly drive end organ disease during otherwise suppressive therapy. And we know that the virus persists. These are data from Frank Maldarelli and Sarah Palmer, but similar data from several other groups showing that using very sensitive assays, a so-called single copy assay, you can find evidence of HIV RNA in the plasma of otherwise suppressed individuals. And if you look in the tissues, you can even more readily find evidence of HIV RNA. This is a study now 10 years old from Peter Anton's group in UCLA, showing that among patients with treatment-mediated viral suppression in plasma, using the same viral load assay in the rectal tissue, you see that 60% of people have detectable HIV RNA. So the virus is very readily detectable in the gut. But the extent of low-level viremia in the plasma is not necessarily a strong predictor of T-cell activation. So these are some earlier data from Tony Kelleher's group showing that among patients with less than 3 versus 3 to 50 copies of viral load, there's not much of a difference in T-cell activation. It's only when you get up to much higher levels of viral replication that you start seeing a major effect. Other smaller studies have seen an increase in soluble markers of inflammation, however, but this needs to be validated in larger studies. However, cell-associated measures of HIV persistence seem to be more strongly and consistently associated with immune activation. These are data from Hiroyu Hitano in San Francisco. On the left, showing very little relationship between T-cell activation, CD4 T-cell activation on the y-axis, and the extent of low-level viremia in the plasma. But on the right, you see a much stronger correlation between cell-associated HIV RNA and CD4 T-cell activation. Now, the usual questions come up whether this is cause or consequence. Is it that low-level HIV expression is driving immune activation, or is immune activation driving the expression of HIV RNA? And those questions really need to be addressed in clinical trials. And we also need to know whether this is just passive release of HIV from infected cells or productive HIV replication, ongoing infection of new cells. Of course, intensifying ART with an additional agent might help block the latter, but not really the former. And in fact, there have been several treatment intensification trials over the last several years, adding an additional agent to an already suppressive regimen to see whether we could block productive HIV replication that may have been continuing. And the long and short of it is that most of these studies have failed to identify either a benefit on low-level viremia using a single copy assay or an immunologic benefit on T-cell activation and other markers. However, there are a few exceptions, and these are data from integrase inhibitor intensification trials. And integrase inhibitor intensification may actually unmask very low levels of HIV replication, or at least a reinfection of new cells. And this is shown in the schematic on the left. On the far left, you see the virus entering a cell, being reverse transcribed into cDNA, and normally gets integrated into the host DNA. And cDNA that is not integrated ends up being packaged into 1 and 2 LTR circles. But on the right, with raltegravir or other integrase inhibitors, you block that integration step, and more of that cDNA gets shuttled into the 1 and 2 LTR circles. And so if a patient has some ongoing productive replication and new infection of cells, adding raltegravir might lead to a transient increase in these 2 LTR circles because you're blocking the integration step. And Javier Martinez-Picado's group several years ago, in fact, showed this in a Nature Medicine paper that 2 weeks into raltegravir intensification, there's this transient increase in 2 LTR circles in cells, suggesting that about a third of patients in this particular study had some evidence of new ongoing infection of CD4 T cells despite viral suppression in plasma. Now, this was a controversial paper at the time. Several groups were very skeptical of this observation. It did suggest that among those who had this evidence for low-level replication in the light blue, this positive 2 LTR circle increase, they ended up having a reduction in T-cell activation during treatment intensification, whereas those who had no evidence for ongoing replication had no benefit of treatment. But this, as I say, was controversial, but later confirmed by a clinical trial of Haruo Hitano in San Francisco, seeing the same thing, a transient increase in 2 LTR circles during raltegravir intensification. And what's more, in her study, she saw a significant decline in D-dimer levels in the raltegravir group. She did not see a benefit in other immunologic markers, including T-cell activation, but one of these markers that predicts mortality did improve somewhat. And why might this be going on? Why might patients have some ongoing productive replication despite an undetectable viral load in plasma? Well, one potential mechanism comes from Courtney Fletcher and Tim Shacker's group in Minnesota, just published earlier this year. The observation that while we get very good drug levels in the peripheral blood, we may not get adequate drug levels in the lymph node tissue where most of the HIV lives. And what their study found is that all patients that they sampled on suppressive antiretroviral therapy that were receiving atazanavir or darunavir had no measurable drug in the lymph node tissue, which is just astounding if you think about it. And all of the drugs that they assessed, including tenofovir, FTC, and efavirenz, had much lower drug concentrations in the lymph node than in the PBMCs, and that's what's shown here on the right. What's more, greater lymph node concentrations correlated with faster decay of virus in the lymph node tissue during a longitudinal study of patients initiating therapy. And so this is consistent with, though it does not prove, that there was some continued replication in lymph node despite ART. The drugs may not get in there as well as they should. But all that said, productive replication cannot be the primary driver of immune activation during otherwise suppressive ART. As I said, many of these treatment intensification studies fail to show an immunologic benefit in most patients. And so we have to ask whether passive release of HIV from infected cells can itself be a cause of immune activation. Now, there's a very intriguing presentation that I'm waiting to see this afternoon from the NIAID in Cliff Lane's lab, suggesting a potential mechanism by which HIV may induce immune activation despite viral suppression. And we need interventions to block this. None of our drugs block expression of HIV from infected cells, and the cure world is working on interventions to flush HIV out. But if we're unable to cure people, I wonder whether it may make sense to actually try blocking HIV expression from infected cells. And this is in many ways the same line of thinking that Eric Verdin was mentioning in his talk on Monday. Now, do other viruses contribute to persistent immune activation during suppressive antiretroviral therapy? Well, one of the first ones to consider is hepatitis C. And we know from an earlier study from Johann Sandberg's group that treatment with interferon and ribavirin that suppresses hepatitis C replication, in fact, leads to a reduction in both CD8 T cell activation on the left and CD4 T cell activation on the right. And several other groups listed here have been looking at soluble markers of monocyte activation and inflammation, and some have shown some benefit. Though I think we need larger studies in this area, and in particular studies that look at direct-acting antivirals. Of course, interferon may have direct effects on the immune system, and so it'd be nice to see whether treating hepatitis C with drugs that do not have direct immunologic effects improves immune activation. Our own group has been very focused on CMV as it elicits massive immune responses even in the absence of HIV infection. And these are data from Louis Picker's group published several years ago showing that 10% of the circulating memory CD4 and CD8 T cell repertoire are CMV specific in CMV seropositive individuals who are healthy, asymptomatic. And this is just astounding. And we see even higher frequencies of CMV-specific T cell responses in HIV-infected individuals. Now, what's more, working with Priscilla Hsu, we've seen that both in HIV negatives, shown here, CMV-specific CD8 T cell responses are positively correlated with the extent of atherosclerosis in the carotid artery. We see the same thing in HIV-infected individuals in red. And what you'll notice from this figure is that the HIV-infected individuals have both higher CMV-specific T cell responses and greater degrees of atherosclerosis. And we've wondered whether CMV, another virus, might actually explain some of the increased risk of cardiovascular disease that we see in HIV. CMV actually replicates in the endothelium, unlike HIV, which tends to be where the reservoir tends to be more in the lymphoid tissues. And further along these lines are data from the Arcana cohort suggesting that among HIV-infected individuals, those that are CMV antibody positive have a higher risk of serious non-AIDS events, including cardiovascular events. These data were presented a few years ago. And all these observations led us to do a clinical trial of valganciclovir a few years ago among patients with suboptimal T cell recovery during antiretroviral therapy. And that study showed that, in fact, treating CMV and potentially other herpes viruses reduced the level of T cell activation in the setting of antiretroviral therapy, suggesting that CMV may well be one of the potential drivers of immune activation in this setting. Also of note, Sharon Walmsley's group published a trial of valacyclovir last year in CID. Valacyclovir, of course, is active against HSV1 and 2, but not CMV. And that failed to decrease immune activation. So I think the two studies together might suggest to us that CMV may be the more important herpes virus in driving immune activation. So to conclude, persistent immune activation during ART is an important problem. HIV persistence may well contribute to this, whether it's a passive release or cryptic productive HIV replication. These may modestly contribute to immune activation, but other viruses are likely to contribute as well, including hepatitis C and CMV. And so with that, I'd like to acknowledge my collaborators and funders. Thank you.
Thank you very much, Peter.